So let's get going. There's my disclosure. I am the founder of 3D Biopsy, and we're going to spend some time talking about that technology. So prostate biopsies, we all know, are quite common, 1.2 million times a year in the US, 3.4 million times worldwide. Although the numbers have gone down, according to a recent survey of global data, we're probably around 750,000 per year, and we know the reasons for that with overdiagnosis. 95% of the procedures are done in the office by a truss technique, whether it's 12 systematic cores or it's with image guidance, and only 5% are done by the transperineal route. However, there is a new office procedure. I'll share that with you. This is the precision point device that Dr. Matt Alloway from Maryland developed that attaches to the transrectal probe. This is a linear array probe, and there's the device. It's got a little puncture site, so you don't need to make multiple punctures of the perineum. You guide the needles by arcing the probe up or down or right or left, which moves the prostate as you move the probe, and you use a local anesthesia, and you can do 12 systematic cores. This is their algorithm of where to take the cores. The initial publications on this data is it's pretty acceptable from a pain perspective. There's virtually no infection rate. There is some minor retention rate, and this is just getting introduced into the clinic in both the US and Europe, and we'll see how it plays out as an alternative to transrectal biopsies. So far, there's no information on image fusion, but it'll be interesting to see if companies come up with a fusion device so you could do targeted biopsies by the transperineal route in the office. The units today that do transperineal image fusion biopsies, a common one is MIM, usually require significant anesthesia, although that's also now being accomplished with a grid in the office with sedation and a wide field local anesthesia. Okay, so why do we need to change our biopsy approach? I think you heard from Dr. Marks. We're totally dissatisfied with the current results we're getting from our 12-core systematic biopsies. It was great when it was introduced in the late 80s and early 90s because it was hard to miss a clinically significant lesion. Now most patients we see have T1C disease if they have prostate cancer, and you don't see a lesion, you don't feel a lesion. We're doing blind sticks, hoping to find cancers. 1/3 of patients have to have their biopsies repeated because we missed the cancer. There's a 40 to 50% upgrading between the diagnosis of the prostate cancer by biopsy and the radical prostatectomy specimens, and we're operating on patients that end up having Gleason 6 disease. It used to be 50%, but that number is lower now because of active surveillance. So clearly, we need to change our strategy. We are our worst enemies. It's no wonder that the task force said we shouldn't be doing PSA screening because it causes more harm than good, because when 50% of the men you operate on didn't need to have surgery, I would agree with that assessment. So investigators like Dr. Marks and others are trying to push us to a better way. So what do we need to do? We need to determine the true pathology or risk group of the prostate. We need to improve lesion localization, and that may improve our approach to how we decide to treat the patient. And precise lesion localization and grading may provide a pathway to targeted focal therapy. I personally believe, and this is an estimate, that probably 50% of men who are newly diagnosed and need therapy can have focal ablation and not total gland treatment, either removal or irradiation. I think that's the goal we need to get to. How we get there is the real issue. So this is not meant to downplay MRI. MRI has a tremendous benefit now in helping us decide who needs to be rebiopsied. If a patient has a clinical suspicion of prostate cancer, you take a biopsy and it comes out low risk, or comes out negative and you're still worried, you get an MRI and you see a PIRADS 4 or 5 lesion, that patient definitely needs to have another biopsy. And now you know where to do it. So MRI has been a big benefit, but we have to understand its limitations. And I'm going to use a lot of Dr. Marks's data because he's published most of this stuff to look at this study, whole mount study that they published at UCLA that showed when you have multifocal disease, which you heard yesterday from Dr. Lucia is about 74% of men, that the MRI misses the majority of lesions smaller than 10 millimeters. They're smaller than 0.5 centimeters, which is still is a pretty big lesion. This is a diameter, it's 89%. And when you look at which of those are clinically significant, you can see the 3 plus 4s was 37%, and the 4 plus the 3s were 29%. So over roughly a third of the men with clinically significant disease are not detected by an MRI. Now, what is your focus? If your focus is, I want to find that lesion, and if it's a clinically significant lesion, and take out the prostate, you got the right answer. But if you're looking for those patients that would fit into the paradigm of, I only need to treat 1 or 2 lesions in the prostate, and they're small, these are small lesions, then if you rely on MRI, you're going to be left short because you're not going to be finding those lesions. That's the dilemma we have to deal with. Here's another paper. It came out with very similar results, a recent publication in 429 patients. MRI missed 50% of all lesions. It missed 82% of lesions less than 1 centimeter, and it missed about 30% of lesions Gleason grade group 2 or higher. And that number, 30%, missing clinically significant lesions, is pretty much a common theme when you compare whole mounts to MRI. This again is Dr. Marks's, one of his papers, which showed us that if you're considering focal therapy, we're going to use MRI, we're going to find the index lesion. Okay, we like that idea. And now we're going to apply the therapy to that index lesion and a focal platform. How big do you make the zone of ablation? So here's an example of their study showing the whole mount and in red and the MRI co-registration in green, showing how the borders don't really match up, and the actual average was about 1.3 centimeters. So a lot of individuals now who are pursuing this, they take a more aggressive approach, and so if they know this is the lesion, they'll do a hemiablation just to make sure they cover all the margin. But what's not happening is, okay, over here, there's 30% of the lesions you don't see. So we're going to do a hemiablation here, and we're going to miss the smaller lesions on the other side. That's a real problem, and I think under clinical investigation, this makes a good sense to look at the limitations and try and figure out how to get past them, but in clinical practice, I don't think we should be doing this yet with any technology. This is a paper from NYU, Samir Timnasia and Herb Lepore's group. What they did is they took a number of patients, they did MRI, they planned out focal therapy. They didn't do the focal therapy. They said, okay, this is where we're going to do focal therapy. Then they did prostatectomy, and they found that 49% had lesions outside of the field of focal therapy if they had done focal therapy. So let's talk about transperineal mapping biopsy. This is one of my fellows who now works in Higia Hospital in Athens doing a transperineal mapping biopsy. You can see the typical grid. He's looking at the monitor. You can see the needle going in. And this is what I did at Sinai before I retired. This is what Dave Crawford did that Dr. Lucia just showed you. So, and this is all those papers you saw being presented by Dr. Lucia. This is how everybody does, for the most part, template-based transperineal mapping biopsies. The patient's in the same position as we do brachytherapy, and it's the same equipment. So if you're a brachytherapist, this is quite familiar to you. However, who's going to spend 2 hours doing this procedure, taking 100 biopsies? Nobody. That's why 5% of the biopsies are done by transperineal. So not only does it have limitations in time, it has limitations in the instruments we use. Those instruments, those biopsy devices, were designed for truss biopsies. They weren't designed for transperineal. And how are you going to know where those, you take 100 biopsies, how the heck are you going to know where those biopsies are coming from if you want to go back and do focal therapy? So it was clear to me that there had to be a number of changes. It couldn't change one thing. You had to change everything in order to make this system work. So I was fortunate. I retired from clinical practice in 2012 and moved to Colorado, and I hooked up with Dr. Crawford and Dr. Lucia and Dr. Bears in the audience here, and we sat down and we said, what do we need to do to try and solve this problem? So we realized we needed to change our biopsy devices. We needed to develop new software with the idea of finding the discrete lesions and then be able to use that software to guide focal therapy. And the other challenge is specimen handling is a major issue. If you could not figure out how to get the specimen to the pathologist intact, full-length specimen, so he or she can report back to you where the cancer is on that specimen, we were never going to be successful. All of those problems needed to be solved. If you couldn't only solve one or two, we're not going to be successful. So that was a challenge we started in 2012. So let's talk about the biopsy devices. So this is your typical biopsy needle we use today. This is a barred needle. It's got a 2-centimeter notch in the needle. It's got a lancet tip. So we first said, all right, we want to be able to take a biopsy that spans the length of the prostate, and it didn't matter if you were doing a transperineal based apex specimen or you're doing a transrectal posterior capsule to anterior capsule specimen, and if you're doing MRI, you would be able to take a biopsy from the posterior capsule through the region of interest and all the way up to the anterior capsule. That would be a much better biopsy for a fusion biopsy. So we first built this needle, that 6-centimeter notch. Then we noted that when you take a biopsy with the current tool, this is a 20-millimeter notch, the average length of specimen is 12 millimeters. So you lose 40% of specimen, it fragments, and what happens is when the cannula comes over the notch, it accordions the specimen to the far end. So if you're trying to do a transperineal biopsy and you want to know is there any cancer along the length of that specimen, you get 60%, you're like, okay, what's the other 40%? So I hypothesized if we put these ridges in, as the cannula comes over the notch, the ridges would hold the tissue in place, wouldn't cause it to accordion or fragment. So that was the concept behind this new type of needle. So then we looked at, this is a representation showing a straight path with a needle and the actual needle going in the prostate. You can see the deflection. So the current needles are lancet tips, and there's a fair amount of deflection, and we're trying to see if we can get this to go straight and not move off the target, especially if it hits a hard cancer nodule. I've had a number of clinicians tell me when they do fusion biopsies and it's a hard nodule, that needle just bounces right off, and I'm sure Dr. Marks can share you with his concern and experience with that. So we had to figure out how to get a needle that didn't deflect. So what we did is we just played with the tip of the needle, and we finally came up with this trocar tip 3-faced needle after much testing and compared it to the bar needle, and you can see on the, and this is in a hydrogel, on the deflection, we got it down from 0.9 millimeters or 1.9 degrees down to 0.2 millimeters or 0.1 degree, and that's how we developed that non-deflecting design. So the needle has a trocar tip, it has the ridges. We also had to figure out the angle and the type of tip to put on the cannula, because as the cannula came over the core bed, if it didn't pierce the tissue properly, it tended to push the needle down, especially if you're taking this long length, and it causes deflection. So we had to find a piercing tip, and we were able to engineer that out. And this is the experiments we did in porcine kidneys showing you can get nice, robust, full-length, non-fragmented cores. So the next thing was to develop the device to carry the needle, and it had to be very comfortable and familiar to urologists. So we went out and did surveys. What would you like? Where would you like the lever? How would you like it to look, et cetera? And we came up with this device. It's a reusable, and this insertion tool with the needle is very familiar to urologists to use. And this is a dial, so you can change the distance of the throw. Here I am working in the lab, showing you can dial this gun between 20 and 60 millimeters and take a specimen between 2 and 6 centimeters, at least for the 15-gauge needle. We're going to, we're now building and testing 15-gauge needles, which will have a 6-centimeter core bed, 17-gauge needles, which will have a 5-centimeter core bed, and 18-gauge needles, which will have a 4-centimeter core bed. And the idea here is you can use them for transperineal or transrectal work. I don't think anybody's going to want to use 15-gauge transrectally, but 17 and 18-gauge certainly can be used for standard truss biopsies or for fusion biopsies. The next challenge, of course, was length. So here's a representation showing I'm using my current needle. It only goes halfway through the prostate. And then I have to take another biopsy at the same spot, and I start here so I can get this part of the prostate. So I'm taking 2 inline biopsies. Does that make a difference? Do you need to take the whole length of the prostate? It's nice for me to say, okay, let's take a length base to apex or posterior to anterior, but does it mean anything in terms of the diagnosis of prostate cancer? It probably means something for localization, but does it mean something for diagnosis? So we set out to try and determine that with current biopsy techniques, if that really means something. So this paper will be coming out in the Journal of Urology in August. And what I did is I took the data from the University of Colorado, where Dr. Crawford practiced more of the Barzell technique, which is inline biopsies, and data from the fellow I trained who worked in Higia Hospital, where they did more similar to the European technique, taking just 1 biopsy per grid point and not taking inline biopsies. And what we show with this paper is if you could define the biopsy density as the number of cores per cc. So for example, if your biopsy density was 1 and it was a 40 cc prostate, that's 40 biopsies. If your biopsy density was 1.5 and it's a 40 cc prostate, it's 60 biopsies. And as you can see, as you increase the biopsy density, the cancer detection rate goes up, and it goes up substantially. This is the group of patients that were biopsy naive, had negative biopsies, or they had Gleason 6s and they were being checked for whether or not they had higher grade disease before being put on active surveillance. And the biopsy density was highly significant in both the positive mapping biopsies and in differentiating patients between Gleason 6 and Gleason 7 or higher. So one of the criticisms of taking so many biopsies is that you're just going to find more Gleason 6, but that doesn't turn out to be true. You actually find more high-grade disease. So I went through the literature. Dr. Lucia showed you some of the papers, and I did this regression analysis, and I plotted all the papers I could find that had reported biopsy densities. In other words, they report their volumes and the number of cores they took per cc and their cancer detection rates. The red dots represent our study and the black dots represent other papers. And it actually came out really nicely. The R squared was 0.7, which is very high for a regression analysis in anything medical. The point being here is here's the 1.5, the 87%. And here is where you are when you're at the University College of London. Everybody knows that's where we have all the great PROMISE studies and everything. So the validation for those studies is here. So all transperineal mapping biopsy is not the same. When you read the literature and you're looking at the correlation between transperineal and an MRI or a radical prostatectomy, and you say, yeah, it's not so good, you've got to look at the biopsy density because it's a major factor in determining. So where does that get me back to? Yes, it makes sense to take a long biopsy and get all the tissue because now we have data to show us that that has a clinical significance. All right, software for mapping. I'm very fortunate in being able to work on this part with Dr. Baird for our alpha version because in the late 90s, when I got interested in software for brachytherapy, none of it existed real time. I got to meet Dr. Ted Jackson, who had a little company called MMS and down in Virginia, and we spent 2 years working together to develop a real-time brachytherapy platform. And that little company was eventually bought by Varian, and it became VeriSeed 7.0. So that experience allowed me to sit down and figure out how we need to develop software for this mapping procedure. So we wanted to go from this to using information similar to this. This was a paper by Kepner, and Kepner came out in 2010. What they said was, if you drill holes in the prostate, and those holes are parallel, and you know the size of the hole, size of the core, and you know the spacing of the core, you could define, in theory, the size of the lesion you would not hit. In other words, what's the sensitivity of finding a cancer? So the way it works out is if you take a 15-gauge needle and you space the needles at 5 millimeters, this is simple math, then the size of the space that you don't sample is 3.5 millimeters. So 5 millimeter spacing gets us down to a lesion detection of 0.02. In theory, 0.02 cc's. If you could detect Gleason 8s less than 0.2, not 0.02, that's 10 times larger than this, Gleason 8s start to become metastatic when they get larger than 0.2 cubic centimeters. You can essentially change the way prostate cancer is managed, because maybe many of these higher grade lesions will be found earlier. This is theory, it's not in practice. So that's how we built the software. This is the pre-commercial version. It looks like a brachytherapy platform. It made it so it's extremely urologist user-friendly. It's on a touch screen. You can use your finger to do everything. You collect the images in axial, just like you do brachytherapy. The program gives you the biopsy plan. It tells you how far you need to dial the gun when you're on needle number 1, needle number 2. You can see the needle coming in here, the white flash. The green dot represents needle number 1. Just like brachytherapy, you line it up in axial, so it overlays that, so the representation is accurate. It tells you how many cores you need to take. It tells you how much tissue you're going to remove. It tells you the largest gap between needles. I mean, it's loaded with information that's actionable if you want to use it. There it is in sagittal, so you line it up in sagittal, and it shows you the length of the core. There's the length of the core. When you're there, you say, it's too short. I want 1 more millimeter here and 1 more millimeter there. You could just click on the needle and change that and adjust the gun so it accommodates that length. What do you do with the information? So everything is numbered 1, 2, 3, 4, 5. So you're not thinking it's B2.5, which is totally confusing. So let's say you finish the procedure and biopsy number 7 is positive. You get this back from the pathologist, and the pathologist says, well, this cancer starts 2 millimeters from the base, and the length of the cancer is 10 millimeters, and the type of cancer is Gleason 7, so you populate that. This is a urologist sitting in his office doing this work. Very easy to do, and then it pops up and shows you the lesion. Now, remember I talked to you about size of lesions and some of the problems with the MRI. You need to know, if you're going to go to focal therapy, the size of the lesion. So there's a slide tool down here that allows you to adjust the diameter in the X and the Y plane. The Z plane you know, because you've got the entire length. So here's a representation of the lesion here in red. What do we know? Well, we know there's cancer in that core. We know how far it is from the base and where it stops before you get to the apex. But we don't know what's outside this red zone. What we do know is there's no cancer here, 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 here. So now I can grow this lesion to accommodate this whole space. We're using the slide tool, and I know there's no cancer in any of these spots, if that was the case. So now I know my safety zone of ablation. Now I don't have to ablate this whole part of the prostate. If this was one Gleason 7, I can do an ablation here. Okay, the last thing I want to show you is how we're going to protect a specimen. This took a lot of engineering. This is the way we do it now. Pick it up, put it in a vial, it falls apart, it gets to the pathologist, it's a mess. Good luck trying to figure out where the cancer is. So we invented this device. This is a woven polyester. It's like a little taco. You lay the specimen. This is a 6 centimeter specimen out of a liver, human liver. And it attaches to this tacky Velcro strip. You remove this piece of paper here, it folds over and secures the specimen. So now it goes to the lab like this. It's secured in the specimen. It can be accessed through this clear polyester fiber so they can see how long it is. Now this is 6 centimeters. Pathology cassettes are only 3 centimeters long. It's not going to fit, and we're not going to go change the world. So it says cut here. So you make a cut there. This is done in the lab. They ink one end. They ink the other end. They put it in the tissue processing cassette. So this is base, this is apex. It gets processed intact. It never gets removed from the carrier. Here you see it being sliced on the microtome. There's the unstained tissue, and you see the carrier in the background here. There it is on the slide, stained, and there it is with the green right there, stained, showing. You can barely see the little fibers here. So this will be a home run, not just for prostate, but for all pathology, because it removes the 3% specimen provenance errors we deal with today by securing the specimen in a device that's barcoded. So all 4 components, not available yet, still under testing pre-FDA, are going to be a big, I believe, going to help us get to this problem. So in conclusion, a 3-dimensional transperineal approach utilizing software, and the software can use MRI. We're not discounting MRI. There's an MRI modules with our software, so if you want to do fusion biopsies with the software, it's part of our own software. You don't have to go out and buy Dynacat or something else. It's included with the package. We can find cancers as small as 0.1 cc in theory, has to be proven. Can this platform serve as a virtual prostatectomy? Again, that'll be proven by when we do the clinical studies and compare it to whole mounts. And if we can get this done, I believe we're going to be on a better road path to getting to targeted focal therapy. Okay, that's it. Thank you very much.